welcome from a cool Cape Town. It's a lovely, cool day over here, lots of rain, and we are very thankful, therefore. It's my great pleasure this afternoon to introduce my co-chair. I'm Peter de Jong. My co-chair needs no introduction and won't get one from me. He is Professor Steve Jeffrey. Secondly, we have this afternoon first-line fertility treatment made easy for the general obstetric, how do you say that word, Steve? And gynecologist. And it's going to be presented by Dr. Jack Biko, and he's sponsored by Cooper Africa. Just a word or two about Jack Biko. He's a gynecologist and fertility specialist. He got his MBCHB at Wits and his M.Med from the University of the University of Pretoria. And he's also got a fellowship. He's also had a postgraduate assisted reproductive certificate from Warwick in the United Kingdom, MSc Human Reproduction from Valencia in Spain. Habla español, Jack? Habla español? No, he doesn't speak Spanish. And then a certificate in advanced endosurgery from Kiel in Germany. So without further ado, Steve, are you going to say a few words?
Yeah, thanks so much.
We're going to have, at the end of this, a few words from Lorinda Sinclair from Cooper Africa. And then I can just draw your attention just before we start next week, substance abuse in pregnancy by a person who's well qualified to talk well qualified to talk about substance abuse, but I was going to say well qualified to talk about substance abuse in pregnancy, and that's Dr. Steve Lindo, and that's sponsored by Acellus. So, Steve, would you be able to say a few words?
Yes, thanks so much for joining, and a very special welcome to Jack for doing this topic. Anything that makes fertility easy, I'm sure is very attractive, because I've never really understood most of it. That's probably why I did gynecology. So,
what? Fertility?
Yeah.
I'll tell you afterwards.
Anyway, but thanks so much for joining, and we're looking forward to it. So thanks so much. I don't think we need any more introduction, and you can fire away, Jack. So we've got about 200 people on already.
Wow, so 200. Jack is popular.
Yeah, I'm trying to share my screen. There we are.
Yeah.
Good. Okay. Peter and Steve, thank you guys for inviting me. And thanks to the company to invite me to give this talk. I'm going to make this talk as simple as it's practical, because infertility is a big problem. You'll see later on. It's a big problem, but despite that, we talk about barrenness amidst plenty. Now in Africa, patients who fall pregnant really make a lot of babies. And when families have a lot of babies, there are those couples who cannot conceive. And it doesn't look like there's a problem. That's why we talk about barrenness amid plenty. Now, in our continent, there are high rates of fertility, and at the same time, there are very high rates of infertility. In fact, the world's belt of infertility lies here in Southern Africa through Central Africa into West Africa. This is the worst area where there's infertility, but it's not seen because those who have kids have plenty of children. There's a big problem. This talk is important because we want to encourage our gynaes not to delay treatment. Now, female reproduction is poor and very inefficient. They only utilize about 1% of the ovarian follicle pool. Things are so bad that by the time our ladies turn 30 years old, there's only 12% left of the ovarian follicle pool. And by the time they turn 40 years old, it's only 3% left. So you can see our concern why we don't want treatment of infertility be delayed. We cannot afford to delay this treatment. It applies to men as well. There has been a big problem over the last 50 years. As you can see in the graph there, in 1989, 64% of our sperms were regarded as normal. The proportion of normal sperms has been declining significantly over the last 50 years. In fact, today, as in 2010 and today, we are happy if a male sperm has at least 4% normal sperms. We've dropped from 64%, and now we're happy with 4%. What has happened? A couple of things has happened. In the last 50 years, the sperm counts have dropped, but at the same time, the use of chemicals has gone up. So there's a big increase in chemical use, and it seems like, amongst other things, that has impacted negatively on our reproductive outcome.
Sorry, Jack. What chemicals are these? Or are you going to tell us just now?
EDCs, we call them endocrine disrupting chemicals.
Oh wow!
Those are common. They are all over the place. In our makeup material, there's EDCs. In the stuff the ladies put on their fingernails, the paint they use there, there's EDCs. In the plastics that we carry our food in, there's endocrine disrupting chemicals. They are ubiquitous in agriculture, everywhere they are there. The beauty products contain EDCs, unfortunately. So you are in for a long ride. We all know the effects of advanced maternal age, but advanced maternal age also has got a problem. Therefore, we cannot delay starting treatment for infertility. We know with advanced maternal age, there's increased incidences of miscarriages, there's increased incidences of stillbirths, there are problems with bipolar disorders and other disorders. In fact, if you look at the men who were conceived whilst their fathers were elderly, there are some issues. I mean, President Zuma's father was elderly when he was conceived. Trump's father was elderly when he was conceived. And Peter, your father was all right now?
No, my father was a young man when I was conceived. They didn't tell anybody.
So there are issues with advanced paternal age, achondroplasia, osteogenesis imperfecta, all these kind of problems. They do occur at a higher incidence in patients of advanced paternal age. Now, infertility is the inability to conceive within 1 year of regular unprotected intercourse. We can't afford to wait more than a year in the young patients. And in those who are 35 years and above, we can't afford to wait more than six months. Because remember the graph that showed us the decline, not only in a quality, but also in a quantity. Now, if a patient has got a reason for not falling pregnant, like she's got endometriosis, or she's 40 years and above, or she's got PCOS, or she had the previous ectopic pregnancy, stuff like that, there is no need to wait for 6 months or to wait for a year. They require treatment immediately. Let's put things into perspective. The chance of a person falling pregnant, the chance of a couple falling pregnant when everything is fine is only 20% per month. So that is when everything is fine, it is 20% per month. Keep that in mind for later. So now, because of the decline in fertility rates, there has been a boom in ART processes. In fact, today, 1.4% of all kids born in the USA were born through the assistance of us, reproductive medicine specialists. In Sweden, 5 to 6% of kids born today where their parents were helped by ART specialists. We are having a serious problem of fertility, gentlemen and ladies. So we were asked by the Department of Health to set up guidelines because this is a problem. So we have developed the National Clinical Guidelines for Safe Conception and Infertility. These guidelines are available. Our aim here was to make sure that all of us, from primary care to quaternary care, each one of us has got a role to play in the management and, importantly, in the prevention of infertility. So these guidelines clearly state what must be done to prevent infertility and what the nursing sisters must do, what the GPs must do, what the gynecologists must do, and what we, fertility specialists, must do. So according to our guidelines, there are 4 levels of care. And what I'm going to talk about today is the level 3 care. Now, level 3 care means that there's a gynecologist available in that particular center, or it's a private gynecologist or based in a state hospital. So I'm going to concentrate mainly on level 3. Level 1 is primary care, level 2 is regional hospitals, number 3 is tertiary hospitals or gynecologists. That is the talk for today. What must the level 3 specialist do? So what's causing infertility? Well, there are male factors and there are female factors, and then there are combined factors. So there is no point in one person pointing a finger to the other one because the contribution is the same. Be you male or female, it's basically equal contribution. I want to emphasize the point that fertility is not a person's problem. It is a couple problem. As you can see in this diagram here. Now, if the gentleman is sterile and the lady is sterile, they will not fall pregnant. There's going to be no pregnancy. But if the male is subfertile, if the male has got a little bit of a problem, but the lady is completely fertile, they will probably fall pregnant. The same thing happens on the other side. If the male is completely fertile and the female is subfertile, the couple will probably fall pregnant. The difference here will only be that it will take them more than a year to conceive instead of a normal time of 6 months to 1 year to conceive. So if one of the two couples has got a bit of an issue, they will still fall pregnant, but it'll take a little bit longer. Therefore, infertility is truly a couple problem and not an individual problem. And our approach should be as such that we should approach the couple. And in discussing the issues of infertility with the couple, it is very important that as doctors, we don't assign blame. We should never say, no, this is a male problem or this is a female problem, because that sticks in the head of the persons and causes severe psychological impairment in the person who's blamed. So always keep in mind, it is a couple issue. Whatever we should do it, let's do it in a particular way that we should involve the couple and not the individual. All right, now let's come to the female factors which contribute to infertility. Okay, we know there's ovulatory factors, and the commonest one is polycystic ovary syndrome. And then there are those patients with primary or premature ovarian insufficiency, wrongly referred to as premature menopause. I have to explain this, ladies and gentlemen, that primary ovarian insufficiency, in fact, even menopause, patients who are menopausal still have eggs. The fact that they don't menstruate doesn't mean that they don't have eggs. It's a topic for another discussion. But patients with primary ovarian insufficiency have eggs. If they don't want to conceive, you have to put them on a contraceptive pill. The next important cause is tubal pathology, blocked tubes from whatever source, whether it is from infections, previous ectopic pregnancy, bad surgery before, and then there's uterine pathology, then the cervical pathology, and then there's peritoneal disease. Just briefly about the uterine pathology, I don't have a slide on that. The commonest thing we have there is things like fibroids. Now, fibroids are very common benign tumors in our ladies. Now, the figure classification, which was published in 2011, was published to guide us as to which fibroids should be removed and which ones should not be removed. Now, I frequently see patients who come to my clinic, they had their myomectomy by the gynecologist. When I see them, there's still that 1 centimeter fibroid that sits in the cavity, and that is a problem. So that big fibroid that our colleagues sometimes remove sitting subserosely somewhere else is not really the major problem. So as a result, whenever we in our clinic do myomectomy, be it open or laparoscopically, we always assess the cavity. We always do hysteroscopy, because if you do an ultrasound and it's a big fibroid in front of you, you're going to merge the small one behind the big one. And it's the small one in the cavity that is actually giving us problems. So my recommendations to the gynecologist is this: if you are going to do a myomectomy on a patient, please ensure the cavity is clean. Even if it's an open myomectomy, I do a hysteroscopy before, and if I look inside before I remove the big fibroid. The important thing about the myomectomy as well is the technique is very important, guys. Remember, we've got a big problem of Asherman syndrome. So when you do a myomectomy, please look after the endometrium. Protect the endometrium. if a patient has got multiple fibroids that affect the endometrium anteriorly and posteriorly, it is okay, it is advisable to do the myomectomy in 2 steps. Remove the posterior myomas and leave the anterior ones, because once you damage the anterior and the posterior aspect of the endometrium, the two are going to stick together and you can get Asherman syndrome. So what we normally do, if there are multiple fibroids, we sometimes do it in 2 steps. I do the one side and send the patient home. After 2 to 3 months, I do the other side when the one side is healed. In that way, we reduce the incidence of intrauterine adhesions or Asherman syndrome. It can
Jack,
be problematic for medical
Jack,
aids.
hello, Jack. We've had a
Yes,
question here. We've had a question over here. Can you just in 2 lines say which women should have fibroids removed and which women don't you have to? Again, it's a jobbing gynecologist, and she wants to know which ones definitely do you leave and which ones definitely do you remove? Apart from the cavity ones, obviously you would take. Obviously, that goes without saying.
Yes, Peter, the current evidence suggests that the only fibroids that should be removed are those in the cavities and those, what we call the type 3 fibroids, those fibroids that touch the endometrium, because that's called the transitional zone of the uterus. But the transitional zone of the uterus is like the pacemaker of the uterus, because the contractions of the uterus start in the transitional zone. And that zone is the myometrial layer between the endometrium and the general myometrium. So any fibroid within 0.5 centimeters of the endometrium sits in the junctional zone. Irrespective of its size, it can cause contractions and thus pregnancy losses. So as a rule, we remove everything in the cavity and everything else does not need to be removed. So from a Fertility Society point of view, we say remove the cavity, and those in the muscles, only remove them if they are more than 5 centimeters. But that's not based on science, that's based on expert opinion.
Okay, thank you.
All right. Then there's this disease, I call it the disease from hell, because those of us who do endometriosis surgery, it's a mission. And the patient who suffer from endometriosis, they suffer. I deal with these patients on a daily basis. These girls, they suffer. When we see them, they have 10, 20 operations. And the reason for that is because patients present to our colleagues with typical symptoms of endometriosis. And then the colleagues want to take it to theater to go make a diagnosis of endometriosis. One should not do that. You should accept that she's got endometriosis just based on the symptoms. There is no need to do a diagnostic laparoscopy to confirm the endometriosis. If you do laparoscopy for these patients, you must do it to go treat the patients. So there is no place for a confirmatory diagnosis laparoscopy. I also struggle to understand why colleagues often do a laparoscopy to diagnose an endometrioma, because we should diagnose it in ultrasound. There's one part of endometriosis that we can diagnose, one on the ovaries and the one on the uterus, that we should be able to diagnose on ultrasound. So it should not be a surprise when we do laparoscopy and find an endometrioma. It simply means that we didn't really check our patients properly. So if there's an endometrioma present, if we remove that endometrioma, we must be careful that we are going to impair the ovarian reserve. It is said that I forgot this guy's name now, that endometrioma don't cause pain. So when patients have an endometrioma, there's often bowel involvement, and that is where the pain comes from, not from the endometrioma itself. So if you do an ultrasound and there's endometrioma, there's a chance, a big chance, there's bowel involvement. And if there are 2 endometrioma, if they are kissing ovaries, then there's a 75% chance that the bowel is stuck between those 2 ovaries. So don't go into those patients if you're not able to resect the bowel, if you're not able to operate the patient, if you don't have skills for advanced endoscopic surgery. So how does it cause infertility? Well, it blocks the fallopian tubes. It also impairs the interaction of the sperm and the eggs, that is impaired. And thirdly, endometriosis impairs implantation. The environment in the endometrial cavity is impaired. You get upregulation of the wrong genes and downregulation of the correct genes. So that causes impairment in reproduction function. Therefore, the treatment for endometriosis, one has to be very careful. If it is for fertility, You either have to do appropriate surgery or you must do IUI or IVF. If it is stage 1, stage 2, we can do insemination. If it's stage 3 or stage 4, we can do in vitro. So it's either you do surgery for infertility or you do ART. There isn't place for medical management per se for patients with endometriosis who want to conceive.
So Jack, so we can safely say that if you've got someone who's got sort of classic endometriosis symptoms and infertility, refer them on to one of you guys, and you might just do empiric fertility treatment or not even do a laparoscopy to check.
Absolutely. Yeah, there is no place for laparoscopy.
Confirming their tubes. So what would you do, an HSG to check their tubes and then move on from there?
Absolutely. So
Okay.
absolutely. So what we do want to say to the guys is this: patients with endometriosis deserve to get one surgery, and that one surgery must count. And the best time to do that surgery is before conception. You do surgery, then they must fall pregnant, or you bypass the surgery and do assisted reproduction, IUI or IVF.
Okay, good.
Okay, Peter. Okay, Steve.
Yeah, thank you.
All right, let's come to PCOS. It's a very common syndrome. Guys, the infertility and the abnormal periods are just the tip of the iceberg. That is what the patient sees as a problem, but she's got bigger problems. She's got chronic inflammation in the whole body. She's at risk for cardiovascular disease. She's at risk for insulin resistance if she doesn't have it already. And when she does fall pregnant, there's a high chance she will get pregnancy-induced hypertension, preeclampsia. There's a high chance she's going to have either small for gestational age babies or large for gestational age babies. There's a high risk of depression and low self-esteem. And eventually, these patients will end up with endometrial carcinoma, breast cancer, and early death. Please note that patients cannot outgrow PCOS. What changes it is the manifestation of PCOS. It changes throughout their reproductive life. In the early childhood, these kids often have premature adrenarche, right? And then in the reproductive age group, they got abnormal periods in infertility. And then in the perimenopausal age group, when other patients tend to have irregular periods in their late 40s, these patients now become regular. They tend to have regular periods, and everybody thinks that they're okay. If we have a 48, 49, 50-year-old lady with regular periods, it's a problem. She probably has got PCOS, right? And if nothing happens, they've got a high risk of endometrial cancer and breast cancer and eventual early death. So PCOS is a serious medical condition that leads to significant metabolic dysfunction and chronic diseases. These patients have to be managed properly from the bottom aspect, not only the top aspect. Yes, Peter?
Jack, do they also tend to have an increased incidence of miscarriage? I see you don't have that over there on the right-hand side. Absolutely. Or not, am I wrong?
No,
they do.
So they don't have. The problem is this: it is obesity that results in increased incidence of miscarriage. And these patients have to be obese, and therefore we used to think it's PCOS, but we now know it's not PCOS, it is obesity.
Okay, thanks. Just another question from Almri Vasson. I think you might know.
No, I don't know.
Okay. In a patient with endometriosis and infertility, if you decide on IVF, does she need self-injectomies if the tubes are partially occluded? She's had 2 ectopic pregnancies after IVF.
No. So this is an issue that changes almost every year. Self-injectomy is no more recommended for anything because the blood supply to the ovary runs just below the tube. I forgot the name of that vessel. It runs just below the tube there. And in the process of self-injectomy, we compromise the vessel artery and therefore compromise the blood supply to the ovary, which in any case is already compromised in terms of quality and quantity. So self-injectomy is no more recommended. So in those patients, so when we do HSG, by the way, and it says there's hydrosalpinx, there's probably no hydrosalpinx because they made it. It's a man-made hydrosalpinx. The only significant hydrosalpinx is the one that when I do an ultrasound, or when the doctor does an ultrasound, you see it. That's significant. And in that case, we rather prefer that you do a salpingotomy and not a salpingectomy, because we want to keep the blood supply to the ovary.
Okay, the name of that, someone knows the name of the artery. It's called the artery that goes below the tube.
That's a good one. That's a good one.
Yeah, so no, it's even for old PID, nothing. You don't, because that's definitely an old thing then.
Yeah.
No, we used to be taught that you do salpingectomies if they've got chronic pelvic inflammatory disease with pyosalpinges. Surely then you should do a salpingectomy if you've got pyosalpinges or these big hydrosalpinges.
Absolutely. Yeah, well, that's an infectious process. I'm sure you have to do that, Peter. It's
Okay.
an infectious process that you must do. Absolutely. You should have symptoms of that, then you must do that. Yeah, I agree. But
Okay.
a simple hyposalpinx, you don't have to do that. All right, now you've got a patient with PCOS, you have to get her pregnant. Of course, if you're a gynecologist, you must try. So you're either going to give this patient Clomid or Femara or Letrozole, whatever you want to give. I can just inform you now, the first line treatment for ovarian stimulation in patients with PCOS is actually Letrozole or Femara. Clomid is the second line, but where there's a money issue, financial issue, Clomid is cheap, then we use Clomid. So if you want to use Clomid or Femara, it is important that with the very first cycle at least, you must monitor the cycle by using transvaginal ultrasound. So you give those patients Clomid or whatever drug you give them, and then follow them up and see how the eggs are growing and how many eggs are developing. Because if she develops more than 2 follicles, there's a high risk of her having multiple pregnancies. Now, from a fertility specialist point of view, and from a fetal medicine specialist point of view, multiple pregnancies are a bad outcome. For a doctor, it looks good. Maybe your CV looks that I got triplets. That's bad for the babies. That's bad for the mom. And that's bad for the taxpayer because those kids go to ICU. They often get CP, and me and other taxpayers have to look after those kids. So multiple pregnancy is not a good outcome for us fertility specialists. We don't like it. If it's going to happen, not more than 2. Yes?
Jack, there's somebody else. They don't know what Femara is. Could you just tell us?
Letrozole, guys. Okay,
What?
Femara is an aromatase inhibitor.
Yeah.
Oh, how do I explain? It's Letrozole. It's a. I think you guys use it in I don't know.
Yeah, no, we're urogynecologists, so sometimes we don't really know a lot about the fertility stuff. So, and I think maybe there are some registrars on you would also be interested. So, the difference in Clomid and Femara, is it just a little bit more controlled, or what would the main advantage of Femara versus Clomid besides the cost?
Okay, now Femara is an aromatase inhibitor. So it is responsible for the conversion of androgens into estrogens in the ovaries and in the peripheral tissue, in the fat tissue. Converts androgens to estrogens. So an aromatase inhibitor blocks that conversion of androgens to estrogens. So therefore the patient will have low levels of estrogen. And that creates a negative feedback in the hypothalamus to produce FSH, which is going to stimulate the follicles to grow. That's how it works. So Femara works on the ovary, giving a negative feedback to the hypothalamus and pituitary gland.
Okay, thank you, Jack.
So that's your preferred one in private practice if the patient can afford it.
Yeah, sure. We don't like Clomid that much because Clomid has got negative effects on the cervical mucus and on the endometrium. So Clomid is anti-estrogenic. So if its effect on the cervical mucus, it makes the mucus to be thick. Therefore, the sperms cannot penetrate to go into the uterine cavity. And then if they do go through, it makes the lining of the endometrium to be thin, and therefore the implantation is less. So with Clomid, up to 80% of the patients will ovulate, but few will fall pregnant.
You'd be surprised how many GPs use Clomid in Cape Town and then refer the patients on after about 10 or so courses, and they say that there's a problem. How many courses are you allowed to do if a woman is having Clomid stimulation?
Now, if it's a very important question. If you don't monitor the patient, you will not see if the Clomid is working or not working. Clomid does not make the patients pregnant. What Clomid does, it's going to cause the eggs to grow. And then she must then ovulate, and then she must then fall pregnant. So what we want to see with monitoring is that, do the eggs grow? If they grow well and she doesn't fall pregnant, it's not a Clomid problem, it's something else. So you need to try Clomid and see this ovulation. If they don't ovulate, then we add an injection to make the patient to ovulate, and then she's going to have sex at a particular time. So it's a bit more complicated than just giving Clomid and sending the patient home. So it is actually incorrect to tell the patient, I'm going to give you Clomid for 6 months and go home, go try it home. That's bad practice because you don't know what happens to the Clomid. It might be working, but she doesn't fall pregnant. So you miss the diagnosis and you waste time.
So on that point, Jack, Stanley Guaru has asked, how do you time when to do the transvaginal ultrasound to check for follicles?
So you would probably start on day 2 or day 3 of a menstrual period, first to make sure there isn't a cyst existing, to exclude any possibility of a cyst at that time. And then you start there with a Clomid or whatever, either on day 2 or day 3 or day 4 or day 5. Outcome is the same. And then you're going to scan again on day 10 or day 11. And at that time, you must see there must be a change in follicle size. So normally on day 2, all follicles are less than 10 millimeters. They're all small. By day 10, we should have 12, 13, 14 millimeter follicles. All right. And the aim is to grow that follicle to more than 18 millimeters, because ovulation normally happens if they're more than 18 millimeters, 18 to 24 millimeters. So once they are on day 10, when you scan them, and the follicle is about 12 millimeters, they usually grow by 1.5 to 2 millimeters a day. So you can actually count and predict when the ovulation is going to be. But this is not necessary. There's a device on the market that can help us a lot. And I'm going to talk about that now.
Okay. And then one last question from Colette Signati. Always uses Ovitrol after a course of Femara or Clomid. Is that a good idea?
And tell us what Ovitrol is, please.
Don't you know?
No.
I don't either.
You're a gynecologist. Now, Ovitrol is HCG. Now, HCG is used for the final ovulation of the egg. So you get the egg to reach a certain size, 20 millimeters, and to help it to break open to ovulate, we give them HCG, and that's Ovidrel or Ovitrel or something like that. It is not always necessary. The pregnancy rate is not higher in patients who got Ovitrel compared to those who did not get Ovitrel.
And it doesn't do any harm?
No, no harm.
Okay.
All right. We don't recommend ovarian drilling for everybody. There are specific indications of which PCOS patients get ovarian drilling, not all of them. Generally, it is the thin patients, not the obese patients, the thin, low BMI patients that will do ovarian drilling, and those with a very high LH. The rest, it doesn't really work well. So if you're going to do ovarian drilling, please drill only one ovary. Don't drill 2 ovaries. And don't make more than 4 holes in that one ovary. And use monopolar energy at 40 watts. And if you put your monopolar in, keep it in there for 4 seconds only. Don't drill the cortex only, but drill deep into the medulla. In these patients, also refer earlier, after 3 cycles, it is better that you refer them to us.
Okay. And then one last question from Subarania Bodasing. Again, what injection is given post-Clomid? Is that also an HCG or something like that? Or is it along the same lines?
Yes, it's HCG, any form of HCG.
Ovitrol.
Yeah. The only problem with that is if somebody, like I said, PCOS girls, often you get 5, 6, 7, 8 eggs growing. If you're going to give HCG, all those eggs are going to ovulate. It's going to be a mess.
Okay. And then seems to be a lot of people using Clomid out there. What is the maximum number of cycles of Clomid you can use? Someone else has asked. Another anonymous person has asked.
All right. So Clomid has been FDA approved to a maximum amount of 150 milligrams per day. There's a maximum amount. If you give it more than 150 milligrams a day, the negative effects on the endometrium and on the cervical mucus are so bad, it is the same as giving the patient contraception.
Sure. Okay.
How many cycles? And how many cycles can you use? The maximum number of cycles of Clomid?
Well, in this country, we tend to use 3. In the UK, where it is state funded, they tend to use 6 cycles. Okay. They want to delay the onset of using ART, so the state always try their best to get the patients out of the system.
All right. And then Yvonne Magweda has asked, what is your take on the use of commercial search test kits to predict ovulation?
I'm coming to that. I'll come to that.
Okay. All right. Thanks.
All right, guys. So lovely lady. The only chance is this: if you are big, there's a less chance of falling pregnant. They require more medication, and Peter, that is a higher chance of getting a miscarriage. All right. And if they do fall pregnant, as we all know, they tend to have a difficult pregnancy in terms of hypertension and stuff like that. Now, what we find difficult is to tell this. So what we find difficult is that to tell these girls, please go home and lose 10 kilograms. It doesn't work. They struggle to lose the weight. They really struggle. So we have to make a decision as to do we help them or do we not help them? And to refuse to help them is a bit of an ethical problem, because there are so many patients out there who are as obese as she is and they fall pregnant spontaneously, and we don't discriminate against them. So we would help them and tell them, listen, ma'am, your expectations should be lower than the average patient. It's going to take us longer to get you pregnant. And if you do get pregnant, expect a lot of complications. They must know that from the beginning. But we cannot say, no, I can't treat you.
And Jack, what about the use of things like Saxenda and these newer drugs? They seem to be working out of all things. I mean, are you starting to use those drugs for weight loss, or is it not something you're actively pursuing with patients at the moment?
No, not really. The only thing that the guidelines, the American guidelines, only they talk about the surgery thing. What do you call it?
Bariatrics.
Yeah. They only say that those patients who are morbidly obese must be bariatric surgery must be recommended. Anybody who's not morbidly obese, you have to take a decision.
Okay.
The other thing we see a lot is the ladies waiting for Mr. Right. They just don't want to make babies until the right guy is there. Guys, the age of the eggs doesn't stop. As we get older, the proportion of eggs which are abnormal goes high. By the time a lady is 42 years old, about 70% of her oocytes are abnormal. So abnormal oocytes generate abnormal embryos. We now know that sometimes you get self-correction within the embryo. The abnormal cells are pushed out of the inner cell mass and pushed into the outer cell mass, which forms the placenta. So the placenta might be abnormal and the baby might be normal. But in general, please know that the older you are, the higher the risk that you're going to have an abnormal embryo and abnormal babies. And the uterus is a biological surface. It's got a job. It's not dead. What the uterus does, there is what we call a crosstalk between the uterus and the embryo. So the embryo secretes chemicals or enzymes, and the uterus listens to these chemicals and enzymes. If these enzymes don't make sense, the uterus rejects this embryo and causes a miscarriage, which truly speaking is a good thing. All right. Now, sometimes the uterus fails in its duties to reject these abnormal embryos, and it just accepts abnormal embryos. And therefore, the baby grows and the mother develops an abnormal baby. So when the baby is born abnormally, it means that the uterus has failed in its duties to reject that baby. It's just science. So if you're going to wait until you're going to get older, what we recommend is please freeze your eggs and free your career. Let's come to the male factor. Oh, sorry, time. Guys, I must rush now. Time, so don't ask more questions. There are many reasons why men don't fall pregnant. They don't make their wives pregnant. Either there's no sperm production, could be from the brain or from the testes, or there's no sperm delivery because the male tubes are blocked, or the sperms are there but they are abnormal, or these sperms don't move forward, they move in circles, or the sperms are there but they go to the wrong place, they go into the bladder instead of going out, or there's just no libido. So those are the basic reasons why guys do not make their partners fall pregnant. Big problem. Our colleagues have 600 million sperms per ejaculate. They've got 10,000 bigger testicles than us. They don't go to gym. They just expose themselves and get fresh air. We go to gym, we've got 1/10 of their ejaculate. We tend to tighten our genitals, and we tend to put all these sperm boiler apps close to our genitals. And therefore, it's not a surprising fact that our sperm counts are going all the time. Problem with male infertility is this: it is a medical and a social blind spot. We tend to concentrate on women and their eggs and forget about men and their sperms. Male fatty infertility is associated with a 30% higher risk of developing diabetes mellitus, a 50% risk of developing heart disease later on, a high risk of these guys abusing drugs. So once a man comes with male infertility, it is important that we are very careful, we deal with them appropriately, and we don't let them stay out of the system. They must stay in the system because we must be followed up to make sure that they don't get these kind of diseases. Many causes of male infertility, I'm rushing now. So what must the gynae do? You take a history, you examine the patient, and the first test you do is a semen analysis. The point is this: many gynaes and doctors send their semen analysis to the normal pathology labs, Ampath and Lancet. Now, those guys are pathologists. They're not fertility specialists. Now, sperms are alive, they're not really dead, so they shouldn't really go to pathology. And the interpretation is often problematic. They would often say poor prognosis, all that kind of stuff. But remember, I said earlier on, the chances of somebody conceiving is 20% per cycle when everything else is fine. So if a man's chance is low, is now 10%, that's not poor prognosis. There's like 50% of the best. So the interpretation of these things, it's important that we set our expectations right. All right. Now, often you get these results, like I said, that the sperm count is abnormal. What does it mean? It means almost nothing. So an abnormal sperm test does not mean that the guy cannot make children. It simply means that it will take him more than 1 year to make children. That's all. Abnormal sperm parameters means that it's going to take a bit longer, not 1 year, maybe 2 years, maybe 3 years. In fact, in their study, Sneak et al. Show that 52% of men with subnormal sperm parameters achieved a pregnancy in 3 years. There are many men with normal sperm parameters who will not achieve a pregnancy because there are other intrinsic factors like DNA fragmentation in the sperm that can impair spermiogenesis, sperm function. So the sperm number might be okay, but the sperm function, which is something that we don't test routinely, might be abnormal. So the sperm test does not necessarily say that you will achieve a pregnancy or you will not achieve a pregnancy. Sperms are nasty creatures. The stuff they don't like alcohol, they don't like toxic stuff, they don't like smoking, they don't like cell phones, they don't like endocrine disrupting chemicals. What they do like are the coenzyme Q10, the vitamins, carnitine, and stuff like that. I'm going to jump this, we don't have test. Another problem that we see is the use of steroids. Now, guys who use steroids,
Jack, you don't have to rush. You still have about another 15 minutes, so don't rush. Yeah.
Oh, okay, I was rushing. Abuse of steroids is a big problem. We often see these big guys working into our clinic when we assess them, and we already know what's the problem. When somebody like this works in my clinic, I know what's the problem. So what steroids do, they grow all the muscles in the body, except one area, the testes. They shrink them. The problem with this is this, therefore, then these guys are going to have no sperm production, all right? But the bigger problem is this, even the heart muscles grow thick. And as the heart muscles grow thick, there isn't space for the blood to circulate within the heart itself. And often you see these guys are fine one day, the next day they're dead, they drop dead because of hypertrophic cardiomyopathy. So they die. So it's not good practice. So what steroids do, what extrinsic steroids do, they block the release of FSH and LH from the pituitary gland. Now it is important to know that there's a blood-testis barrier. So if you take steroids, those steroids are high in the blood, but not high in the testes. So for sperm production, we need the amount of steroids in the testes to be very high. In fact, there has to be 200-fold higher in the testes than in the blood. So now if you block the intrinsic production of testosterone because you take extrinsic testosterone, then the testis levels of testosterone are going down, and with low levels of internal testosterone, you get no sperm production. FSH is required for sperm production. LH is required for testosterone production in the testes. They both go down, and therefore the testes are going to shrink. As all the muscles grow, the testes keep on shrinking and shrinking and shrinking. To treat these guys, they have to stop the use of testosterone. They have to stop the use of testosterone. There's nothing else we can do. They must stop the use of testosterone. I think I'm about to finish now. And then there's obviously sexual dysfunction, you know, if certain medications, diabetic medications, smoking, excessive alcohol intake, heart disease, various surgeries, they switch the lights off. And then these guys will obviously require help from our urology friends. The same thing with the male, I spoke about female. Now, obesity, male obesity is a problem. Firstly, if you are fat, now within the fat cells, there's the aromatase enzyme. So that enzyme is going to convert all this flowing testosterone into estrogens. And that's why these guys often develop gynecomastia, because the levels of estrogen is very high. The level of testosterone goes down, and because of the high levels of estrogen and low level of testosterone, they develop sexual dysfunction. They also have low sperm parameters because, as you know, the testes are outside the body to have lower temperature than inside the body. But if you ask for this guy, those testes are like inside the body. It's hot in there, and therefore the heat in there causes dysfunction of the testes, causes fragmentation of the DNA of the testes, and therefore causes abnormal sperm parameters. So what are the aims of infertility treatment, guys? Well, the aim, it should be simple, it should be safe, we should try to make it comfortable for the patient, it must be cheap, but it must be effective. Now, the word effective is relative. If under normal circumstances, the chances of somebody falling pregnant is only 20%, then 5% success rate, 10% success rate is regarded as effective. Perspective, guys, it's perspective here. All right, now people ask me about what devices can we use. Now, this is an excellent device. It's called the pill kit. Because if you want to use timed intercourse for the patient or IUI, now to do timed intercourse or IUI, the guy must have fairly normal sperm count. We'll never but low morphology here and there, low count here and there, but fairly normal. At least one tube must be patent. The patient must have regular menstrual cycle and not have ovulatory problems. And in those couples in a hurry, we can also do this. And then patients with unexplained infertility can also have timed intercourse. There's a pill kit which helps you to monitor the cycle. Unlike those ovulation kits that you do once on day 14, whatever thing. This kit, it helps the patient because you assess the patient from day 2 of the cycle. So the patient has to buy this kit. It comes with an app on the cell phone. It comes with kits, with LH kits and FSH kits, so it measures everything. So from day 2, the patient does test, and the app tells the patient what she must do. And you're going to get a graph that tells you exactly when are you ovulating, when is the best time to have intercourse. So it's over a period of the whole month, then you can see exactly when is the right time. I prefer this kit than those one kits which will come only on a particular day, because if you don't know your cycle length, you're going to be in trouble with that one-day kit. This kit is going to help you. I'm going to suggest that if you don't know about it, just Google it and then phone the reps to come and talk to you about this. I use it myself in my practice. I use it a lot for those patients with for timed intercourse.
Jack, what about just doing intercourse every second night? I mean, is that any worse than timed intercourse? Why don't they just every 2 nights? Because this timed intercourse is sometimes quite stressful for couples. And if they just do it every 2 nights, if they're not menstruating, isn't that the same effect?
Absolutely. It takes away the stress, Peter, you're right. It doesn't even have to be every 2 nights. Remember, once the sperms are in the fallopian tubes, they can survive in there for 5 days. So even if it's not every 2, even if it's once every 3 days, or even once every 4 days, for as long as there's always sperms in the fallopian tubes, it's going to do. So like Peter says there, often if you measure something, it puts stress. Now we must have sex on this day. And then that sex is like a business sex, not a proper sex, if you can put it that way. And that puts even more stress on the patients. I agree with you, Peter, 100%. So, guys, you can do insemination in your offices. All right. So normally you would not do the natural cycle insemination. Normally you would do the stimulated cycle insemination. So you'd see the patient on day 2 of the cycle. You do a scan to make sure there is not an existing cyst. If it's a cyst, then that cyst obviously is going to produce hormones, it's going to mess up the cycle. So if there's no cyst, then you're going to start the patient on your Clomid or whatever you're using on that day, day 2 or whatever. And then you start usually with the lowest dose, which is 50 milligrams per day. And then 10 days later, on day 10 of the cycle, you see the patient, you scan her. And then once the lead follicle, you've got 2 follicles and one of them is 18 or more, you can then trigger with HCG. And then 36 hours after triggering, you can insert the sperms. All right. So if you want to kill your patient, take the sperm from the husband and put them in the uterus. That's going to kill the patient. Raw sperms are dangerous. We never do that. They contain a lot of prostaglandins. We don't ever use raw sperms and inject them in the patient's uterus. It's extremely dangerous. So what must we do? Because you don't have a lab. I have a lab, so I can take my guys to the lab, we wash the sperms, remove all the dead sperms, wash them, process them, and then we inject the sperms. But if you don't have a lab, there's this device called the septic kit. It's a kit that you can purchase from the companies. And with this kit, you can prepare your sperms in the room and then inject the prepared sperms into the patient's uterus. Now, a study was done in 2012 from the Tiger Book Group, and they found that the implementation of this particular kit, after doing this, there is a 16% pregnancy rate. 16 is very good. 16% pregnancy rate compared to the 8% pregnancy rate when you do the swim up technique. All right, so if you don't have a lab, there's a device that you might try to use and see if it works for you. It's called a septic kit. You can try that kit as well. So concluding my talk, how do we fast track patients to parenthood? Well, guys, shed the excess weight. If you shed the excess weight, it's going to improve the sperm parameters and sexual function. Let's advise our couples to reduce smoking. This will improve the sperm function and also reduce the incidence of ectopic pregnancy. Reduce alcohol intake will also reduce sexual dysfunction, and the patients must take the necessary micronutrients. And please remember that patients are never too young to seek medical assistance. Thank you. I think I made it in time.
You certainly did, Jack. And it's a wonderful talk. There were over 250 people logged on here this afternoon. And it shows you how popular your talk was and all these questions. I'm sorry we interrupted you, but there was this big drive. And now, Jack, I'm going to thank you. And also, I'm going to hand you over to Lorinda of Cooper Africa. And Lorinda Sinclair then is going to say a few words, thank you, and then introduce Cooper Africa. So, Jack, once again, a huge thank you. We see you all again, ladies and gentlemen, in a week's time for Steve Lindo speaking on substance abuse in pregnancy. Thank you, Jack, and good evening to you, Lorinda.
Thank you, Stephen and Peter. Thank you, guys.
Good evening, everyone. Dr. Jack, I want to just say this was one of the best talks that I attended in a while. I loved your practical tips that you gave everyone. I think that actually was just a cherry on the top. So thank you. And we now see that 20% chance of falling pregnant. We've actually now got tips how to help the patients achieve that pregnancy that might elude them. Just with regards to getting hold of some of the devices that was mentioned, you are more than welcome to contact myself. Ashley will display the contact details now. That is the SEPD sperm preparation kit. There is 5 little devices inside a kit like that. And the information will be mailed to you afterwards. The second one is, of course, the pill fertility kit. And again, also, this kit is available through Cooper Africa. And like I mentioned, you're more than welcome to contact me or Pro Distribution. There is the contact details, and we will then be able to supply you. These kits, unfortunately, aren't available at a pharmacy. it is reserved for the gynecologist to buy directly from our wholesaler. So thank you for this opportunity. Over to you, Dr. Jeffrey.
Thanks so much, Lorinda. That was good to see that the stuff is available, and your details will be available from Ashley, and obviously we can Google Cooper Africa and get some of those details as well if we need it. Peter's popped out to go and do a delivery, so he's already left us, but we do have 2 other questions. Jack, if you're still on.
Yeah.
So Kaletzin Yati wants to know, what is the role of AMH in determining follicle reserve? Can we advise egg donation immediately on getting a negligible response?
So AMH has nothing to do with egg quality. It has everything to do with egg quantity. So the fact that AMH is very low doesn't mean that the patient must get IVF or some expensive treatment. It simply says that if whatever I do on the patients, if I do IVF, I shouldn't expect to get 10 eggs, I might get 1 or 2 eggs. But those 2 eggs, I'd rather have 1 or 2 eggs from a 30-year-old girl than get 30 eggs from a 40-year-old girl.
Okay, and then Graham Birdsley wants to know, what are the implications of excessive AMH levels?
All right, so I'll have to go a little bit. Okay, before I go there, okay, guys, about AMH testing, let's not test anybody who's below the age of 35 unless we're worried about primary ovarian insufficiency. So AMH testing should be done in patients of advanced age, more than 35 and so on. What is the effect of AMH on? Second question.
Well, it's the excessive levels. If it's excessive, what is the impact of that?
All right, now in the cell cycle, there are 2 factors. There's the what we call the accelerators, the chemicals, the enzymes that cause cells to grow, and then there are the brakes or the suppressors which push cells in the dormancy stage. In patients with, for instance, PCOS, where the AMH levels are very, very high, the ovaries, the eggs are in the dormant stage. The eggs don't grow. Because they don't grow, they don't see their cycles. So this is the problem with AMH. It keeps the eggs dormant. It saves them for future use, but there's no future. So high levels of AMH means that the eggs are many, but they're lazy. They're not growing.
Okay, great. All right, and then one last question before we go. Does the use of premature ejaculation treatment have an impact on male fertility?
No.
Not? Okay. All right. Good. Well, thanks so much, Jack. You've got a wonderful way of explaining things, very simple, and you've got a lot of good feedback in the chat. Excellent talk. Thank you from Tabita Boto. Suleiman Halen, thanks, Jack. Well done. So
Thanks, Suleiman.
Very much appreciated, and thank you for taking the time to be with us and to actually give the talk. So and I'm sure it's helped a lot of people because it's very practical, and there's still a lot of people needing to have input on this. So thanks, and all the way from Ghana, from Dr. Kofi for Amanfo. Thanks so much. So that definitely brings us to the end. And thanks again to Cooper Africa for their sponsorship. And we'll see you all next week with Steve Linder. And have a good evening, everybody. And thanks for joining. Thanks so much. Bye.
Bye.